Let's go ahead and start. It's 2 minutes past 1 o'clock. Good afternoon, everyone. Given that people are joining from all over, so good morning, good afternoon, good evening, depending on where you are. Thank you for joining our monthly webinar series. My name is Vishwanath. I'm one of the two co-directors of the Lee Kum Sheung Center for Health and Happiness. My other co-director, Laura Kupsansky, is on sabbatical, but we might still see her today at some point in the webinar. So we hold these webinars are actually seminars every month. And unfortunately, because of COVID-19, we shifted to webinars. But we are delighted to have one of our own as a speaker for this month. Dr. Kristen Nishimi is a research advisor for our center, and a Data Science Postdoctoral Fellow in Psychology at San Francisco Veterans Affairs Medical Center and the University of California, San Francisco. Dr. Nishimi received her MPH in Social and Behavioral Sciences and her PhD in Population Health Sciences here at Harvard-Chan. And I'm delighted to say she's also a recipient of our 2019 Dissertation Research Award from our center, the Lee Kum Sheung Center for Health and Happiness. So her research examines the impact of trauma and adversity exposure on both mental and physical health outcomes across the life course. We are delighted this is a part of our ongoing series for this year, the theme being recovery and resilience, which is very appropriate. If you have questions, please put them in the chat. Kristen will talk for about 30 minutes, I guess, 35 minutes, and then we will open it up for questions and answers. So please put your questions in the chat. Jamie is monitoring it, and she will feed me with those questions. So Kristen, we are delighted that you can join us. Welcome home, I should say. Please go ahead.
Awesome. Thank you so much, Vish, and thanks to the center for welcoming me back, even virtually, to give this presentation. It's really an honor to be able to do this. So I'm going to share my screen and present, and let me know if that doesn't look right. Good. All right. Okay. So today I will be presenting on psychological resilience and the potential implications for physical health. So today, first I'll describe the definitions and measurement of resilience, and then I'll briefly discuss the different waves of resilience research over time and present a conceptual model linking resilience to physical health and provide some empirical evidence on that. And then I'll consider resilience during the COVID-19 pandemic. So starting with resilience definitions and measures. So what is psychological resilience? So when we think of the term resilience, we might think of things like elasticity or bouncing back, or perseverance, fighting through adversity, or growing or thriving despite the odds. And these different sort of lay understandings of resilience have all contributed to the scientific understanding of this construct. So when considering psychological resilience specifically, there have been various definitions in the literature, but a brief one that reflects the general consensus is positive psychological adaptation in the face of significant risk or adversity. And this definition entails two core and necessary concepts, and that is adversity, or something to be resilient to, which I refer to broadly, but this can be experiences both acute or chronic that occur across the life course, such as childhood maltreatment, socioeconomic adversity, discrimination, or potentially traumatic events. And then the second concept is the evidence of positive adaptation. And in the case of psychological resilience, this will incorporate things like emotional, psychological, or mental health. So there are different ways to consider or conceptualize this construct of psychological resilience in the research literature. So first, we can think about resilience as a trait or an individual capacity. That is a characteristic of a person to recover from or overcome adversity. And this might be an inherent capacity or something that's developed or changes over time. And it's been measured in the literature using self-report scales, such as the Connor-Davidson Resilience Scale. We can also think of resilience as a set of protective factors. So these can be things both internal to a person or external that can buffer the negative impacts of adversity and promote good outcomes. So this has been measured in a range of different ways, depending on the population of interest and the context, but can be things like individual capacities, like personal competence or personality features, or sets of external factors like social support, community cohesion, or other tangible resources. And then lastly, we can think of resilience as a sort of ongoing process or outcome, which we can define as a manifestation of positive functioning or positive adaptation after the experience of adversity. And so this is typically measured by directly assessing adversity exposure, as well as subsequent psychological functioning, considering how the dynamic experience of adversity occurs over time and how somebody recovers from that. So when I examine psychological resilience in my research, I'm typically defining it as this third general conceptualization as a manifested outcome. So here we can visualize that resilience outcome. So on average, as the burden or severity of adversity increases, the level of psychological distress or poor psychological health also tends to increase on average. That is, higher adversity tends to be associated with higher psychological distress. However, we know there's actually quite wide variability in individual responses to adversity, and actually know that a lot of people tend to do better psychologically than we would expect given their level of adversity. So here's how I like to think about resilience outcomes as evidence of this positive psychological adaptation despite adversity exposure. So how are we going to measure these resilient outcomes, or how do we operationalize manifested resilience? First, we can use categorical classification as a way to classify individuals into different groups based on their levels of exposure to adversity, such as higher versus lower, exposed versus unexposed, and then their levels of psychological functioning following adversity. So we can define higher or lower psychological health. And these groupings identify those who are most resilient, who've experienced high levels of adversity, but also display positive psychological health. And then those non-resilient or with lower resilience, who've also experienced high adversity, but have some evidence of psychological distress or some psychological harm. And then we can also compare with those who have had lower adversity exposure or who are unexposed. And of course, psychological health will also vary across those groups. And these groups allow us to make relevant and important comparisons in the population and identify particular groups at risk. So second, we can create a measure of residualized resilience. So this has been increasingly done in the literature and involves running a linear regression model and then extracting the residuals, where adversity or trauma burden is modeled to predict level of psychological functioning. So here demonstrated as psychological health. So within a certain sample, there will be this predicted relationship, and individuals will fall above or below that predicted best fit line. And here, those who are above the line have higher psychological health than expected relative to their trauma burden, and we say they have higher levels of resilience. So we can use this residual measure as a continuous, empirically derived measure of resilience that's more granular in nature. And then third, measures can take into account functioning across time. So we can consider functional trajectories by looking at psychological health over time after the adversity or the potentially traumatic event. So this is a figure from researchers Galatzer-Levy, Huang, and Bonanno, who've done a lot of work modeling these trajectories across various populations. So as you can see, there are different trajectories that people tend to take, with the resilient group being those individuals who have pretty stable low levels of dysfunction. And other trajectories can also manifest, including chronic dysfunction, a delayed onset, or recovery. And this is the most dynamic assessment of resilience, which takes into account functioning across time and potentially even before an adversity exposure. So now that we've seen these different operationalizations, how consistent or congruent are the different measures? So to explore this, we examined a sample of a little under 2,000 African-American adults from the Grady Trauma Project, which is a cohort based in Atlanta, Georgia. And all of our analytic sample had experienced childhood maltreatment. Therefore, this whole sample had experienced early life adversity. So we looked at 4 different measures of psychological resilience here. The first was the Connor-Davidson Resilience Scale, which is one's self-reported perception of their ability to overcome stress. And then the next 2 measures are categorical, so similar to that 2x2 table I showed. And in this case, everyone in the sample was exposed to adversity. So the second definition classified individuals as resilient if they did not show any clinically elevated levels of depression or PTSD symptoms. And then the third definition was similar, but instead of only considering the absence or presence of distress, we also considered positive affect. So to be classified as resilient, individuals had to have low levels of depression and PTSD, but also high levels of positive affect, which reflects a wider range of the mental health continuum. And then lastly, we calculated residual resilience, like that model I just showed, where we modeled the severity of childhood maltreatment, predicting levels of distress symptoms, and then extracted the inverse residuals such that higher values indicate relatively better psychological functioning. And these are the correlations between the different resilience measures. So as we can see, that despite being essentially operationalizing the same construct, the correlations are only relatively modest. In particular, the correlations between the trait measure, with each of these other resilience outcomes were pretty low. And so overall, this indicates that the choice of operationalizations is very important, and researchers will need to be thoughtful when choosing how to define resilience and when explaining or justifying their measures, as well as when comparing across the broader resilience literature. So now let's consider resilience research and how it relates to physical health. So taking a step back from measurement, we can consider the different waves of resilience research development over time. So research in this area can be considered to have formally begun in the 1970s, with developmental psychologists really interested in how children were functioning well despite high levels of trauma. And since that time, multiple disciplines have become interested in resilience, including psychology, psychiatry, developmental science, public health, medicine, as well as other fields like education and criminal justice. And phases of this research have generally developed in 4 waves. So the first wave really focused on describing the resilience phenomenon at the individual level. And it worked to identify who is resilient and then what are the sorts of predictors or factors that may influence resilience. In the second wave, researchers started to consider more dynamic changes and take a developmental perspective across the life course, which entailed identifying processes that would influence resilience and also considering the social ecological systems that surround an individual. Wave 3 went beyond understanding what resilience is and focusing on how to bolster or develop it. So this involved creating and testing largely psychosocial or educational interventions that might build or enhance resilience in individuals. And then wave 4 has been characterized by researchers integrating different levels of analyses beyond the psychosocial domains. So researchers are starting to consider genetics, epigenetics, and different neurobiological processes, and think about how these might relate to, contribute to, or indicate resilience. So what about physical health? And let's think again about those 2 core resilience constructs, so adversity or trauma, and the demonstration of psychological adaptation or psychological health. So as I briefly noted, adversity can include early life exposures like childhood maltreatment and household dysfunction, and trauma can be defined as events involving death, the threat of death, or serious injury, or sexual violence. And there's ample evidence suggesting that these experiences put people at risk on average for later physical health outcomes, such as cardiovascular disease, diabetes, autoimmune disease, and a range of other chronic conditions. With respect to psychological health, we can consider both the absence of distress, so lower levels of anxiety, depression, or post-traumatic stress symptoms, but also positive psychological functioning, which includes positively valenced feelings or cognitive appraisals. And this may involve hedonic dimensions relating to pleasure and happiness, eudaimonic dimensions relating to fulfilling one's potential and meaning, or more blended constructs like optimism. And there's a smaller but growing body of evidence suggesting that higher psychological health is associated with lower physical health risks. So in order to bring together literature on resilience, as well as what's known about how trauma and adversity, as well as positive psychological health may influence chronic disease outcomes, we've developed this simplified conceptual framework adapted from Drs. Boehm and Kubzansky that link psychological resilience to health outcomes later in life. So resilience is hypothesized to impact health through two main pathways: biological processes and health-related behaviors, both of which can range from more deteriorative to restorative. And resilience is expected to promote more of these restorative processes and fewer of these deteriorative processes. And these pathways in turn will mediate the relationship between resilience and physical health, with greater resilience leading to a lower risk for chronic health conditions across the life course. And then, of course, resilience and these later processes may be influenced by a range of individual, interpersonal, and environmental factors, including sex and gender, race, ethnicity, nativity status, genetic predisposition, socioeconomic factors, and et cetera. So on the whole, this model proposes that resilience to adversity will be protective or promotive of good physical health across the life course. So now I'll share some of our empirical work where we've examined these research questions. So for our first study, we examined how different resilience measures were related to body mass index as a physiological indicator important for health, where we hypothesized that higher resilience would be associated with relatively lower BMI. So using a subset of individuals from that cross-sectional study I just shared, we looked at associations between each resilience measure with body mass index. So just a reminder, this study included a self-reported trait resilience scale, 2 categorical resilience measures, and a residual resilience measure. So we found that higher levels of trait resilience, as well as being considered resilient by the categorical measure, which included positive affect, were each significantly associated with lower levels of BMI, adjusting for sociodemographic confounders. And the 2 other measures, which were focused largely on distress, were not significantly associated with BMI. So it appears that resilience measures may have varied associations with indicators of physical health like BMI. And additionally, measures that seem to incorporate somebody's own perception of resilience, or that also include positive functioning and not solely distress, were associated with this indicator of physical health. So it's possible that incorporating these positive domains or positive dimensions will be important when examining physical health correlates of resilience. So next, we examined how resilience was associated with healthy lifestyle indicators, hypothesizing that resilient individuals would have healthier patterns of behavior and healthier body weight into young adulthood. So for this study, we used data from about 3,700 young adults in GUTS, an ongoing longitudinal cohort. So we defined psychological resilience from early life adversity. So we included experiences of maltreatment or household dysfunction that occurred in childhood or adolescence. And we classified individuals into these 4 resilience groups using that categorical operationalization approach. So namely into resilient and non-resilient for those who have experienced early life adversity and then later demonstrated either high or low levels of psychological health, as well as individuals who were unexposed to adversity. So among these 4 groups, we then compared levels of these healthy lifestyle components. So we looked at the likelihood of being a non-smoker, having moderate or healthy levels of alcohol consumption, meeting recommended daily physical activity levels, having a healthy diet assessed via a standardized self-report measure, and then having a healthy body weight. And we modeled associations between resilience defined at baseline and levels of these different lifestyle components, both at baseline and 5 years later. So compared to the resilient group in blue, which was our reference category, the non-resilient individuals in red were less healthy on 4 out of the 5 components. So specifically, they were 4% less likely to be non-smokers, 6% less likely to do regular physical activity, 14% less likely to have a healthy diet, and 8% less likely to have healthy body weight compared to their resilient peers. And then unexposed individuals who had lower psychological health in young adulthood were also less healthy on 2 of the components compared to the resilient group. And then lastly, the unexposed group who showed high psychological health were more likely to be non-smokers, but were comparable to the resilient individuals on all of the other components. So we found that resilient individuals had largely comparably healthy behavior engagement and healthy body weight compared to their unexposed, psychologically healthy peers in young adulthood. And interestingly, we saw generally similar or consistent patterns of association between this measure of psychological resilience and each of those 5 different components. And we also found that the resilience effects were generally stable across 5 years of follow-up on average. So resilience to early life adversity may be promotive of a more healthy lifestyle and healthier body weight into young adulthood. So next, we looked at the effects of resilience on the risk for incident cardiometabolic disease outcomes. And this included heart attack, heart failure, coronary artery disease, stroke, and diabetes. So in this study, we used data from the Midlife in the United States study, a longitudinal cohort of US adults with self-reported data collected in 1995, 2005, and again in 2014. So among our analytic sample of over 3,000 adults, we again defined resilience categorically based on early life exposure to adversity and then higher or lower psychological health in adulthood. So no one in our analytic sample had any of these cardiometabolic conditions as of baseline. And then we examined incident or newly reported occurrences of any of those cardiometabolic outcomes across follow-up. So adjusting for confounders, we found that those classified as non-resilient had higher odds of disease compared to the resilient group. And additionally, the resilient group did not significantly differ in their disease odds from either of the unexposed groups. And this elevated effect among the non-resilient group held even when accounting for adult socioeconomic circumstances or psychosocial factors like education, income, and marital status, which could be related to the process of resilience over time. And it also held when adjusting for baseline BMI and health behaviors, which are potential mechanisms that we showed in that previous study may be related to resilience. And so because these cardiometabolic conditions were self-reported, we additionally examined objectively assessed biomarkers in a subset of our sample. So we defined a cardiometabolic risk score, which was a sum across 8 risk markers obtained from an in-person clinical visit, including things like blood pressure, lipids, HbA1c as a measure of glucose intolerance, and CRP as a measure of inflammation. So for each of these 8 markers, we defined a risk cutoff based on established cut points and then summed up the number of high risk markers for each person. So when examining this objectively assessed cardiometabolic risk measure as the outcome, the patterns of association were largely consistent. So the non-resilient group had higher cardiometabolic risk than the resilient group, while the resilient group did not significantly differ from the unexposed groups. So this study found that the non-resilient group had elevated cardiometabolic risk relative to the resilient group, and relationships held when accounting for adult socioeconomic status, as well as health behaviors, which suggested that the behaviors we assessed at baseline may be part of, but not all of the mechanism linking resilience with these health outcomes. And importantly, the objective biological measures were consistent with the self-reported condition findings, which strengthens our confidence in these data. So based on this work, it's possible that resilience from early adversity may benefit cardiometabolic health into mid and late adulthood. Now, with the onset of the COVID-19 pandemic, we've considered how resilience might influence outcomes during this universally stressful time. So the pandemic has brought on a massive shift in all of our lives, bringing threat of disease and infection, waves of lockdown and restrictions, economic insecurity and political instability, and all of these things are changing greatly over time. And so rightly, there's been a lot of research interest on the mental health effects of the pandemic. And so while much of this work is focused on negative mental health impacts, a substantial segment of research has focused on psychological resilience in a variety of ways. So I've been working with Olivia Baldi and Carmel Choi to perform a scoping review of early empirical literature amid the pandemic that's focused on resilience. So we've completed this search as of July 2021, And we found 233 peer-reviewed, published empirical papers meeting our review criteria focused on resilience in COVID. And these studies covered a range of populations from countries across the world and have examined resilience as a predictor, a correlate, an outcome, moderator, and mediator. And resilience was typically measured with self-report trait scales, but other measures reflected that manifested resilience during the pandemic or focused on resilience factors that promote good outcomes. However, few of these studies that we found incorporated longitudinal data to ask how showing resilience, even before the stress of the pandemic, might be influencing how people are doing during COVID-19. So to explore how resilience might be influencing outcomes amid the pandemic, we've used data from an ongoing longitudinal cohort, the Nurses' Health Study 2, which includes women who are current and former healthcare workers. And we've included a subset who had all experienced some form of trauma in their lifetime. So we examined psychological resilience among these women, defined categorically in 2018, so before the pandemic began. And we did this based on exposure to lifetime trauma, higher versus lower levels, and then psychological health. And so here we used a slightly more nuanced definition of psychological functioning, which we've classified as unfavorable, meaning meeting clinical levels of depression or PTSD symptoms, adequate or not having clinical distress, but also having lower levels of emotional well-being, and then favorable, so having low distress and high emotional well-being. And so these variables combined to create these 6 resilience groups. And then we looked at how this pre-pandemic resilience was related to mental health outcomes early in the COVID pandemic in about the summer of 2020. So you can see here that the resilience groups were related to distress during COVID-19 in a graded fashion. So in this case, we're showing the effect estimates for depression during the pandemic. So compared to the most resilient group, so those who'd experienced high lifetime trauma, but show favorable psychological health, most of the other groups had higher distress levels during COVID-19. Whereas only those with similarly favorable psychological health, but also lower lifetime trauma burden, had lower levels of depression during COVID. And this pattern held when we looked at other forms of distress during the pandemic as well, including anxiety symptoms and post-traumatic stress symptoms. And we've additionally examined levels of well-being during COVID-19, finding interestingly that prior trauma exposure seemed to be less impactful for whether one had high well-being amid COVID, but this seemed to be largely dependent on psychological health before the pandemic. So we also examined a measure of residual resilience, finding that higher levels of continuous resilience were associated with lower distress and higher well-being amid COVID, as we would expect. And then largely regardless of prior trauma exposure, what mostly mattered for well-being during COVID-19 was whether women had high positive well-being prior to the pandemic. And this is a notably different pattern than distress, which seemed to be more impacted by prior lifetime trauma. And the effects we found were similar between women currently working in healthcare and those not currently working in healthcare during COVID, indicating that resilience may be beneficial for mental health broadly, as well as in acutely stressful settings, such as working in healthcare during a global pandemic. So resilience prior to prior trauma might protect mental health in the case of future stressors. Now, using the same cohort, we determined that the measure of whether the measure of resilience before the COVID pandemic was associated with different forms of coping amid COVID-19. So we were hoping to determine whether women who showed higher resilience prior to the pandemic might not only show more positive mental health, but also might be reporting more adaptive or positive coping strategies during this stressful time. So led by my colleague Ariel, we've looked at that continuous measure of residual resilience with average levels of 2 coping styles. So approach coping, or behaviors that attempt to reduce stress by alleviating the problem directly, which has been a link to more adaptive responses and better physical and emotional health, as well as avoidant coping. So behaviors that attempt to reduce stress by distancing oneself from the problem, which has also been linked to poorer physical and emotional health. And we found that higher levels of resilience were related to higher approach coping, as well as lower avoidant coping, as we had hypothesized. So when we compared those with the highest versus the lowest levels of resilience across the different individual coping strategies, we can see some variability. So here you can visually see that those with lower resilience had higher average engagement in most of the avoidant strategies in orange, and then slightly lower engagement in the approach strategies. Religion and humor are actually not categorized into these two coping styles, and religion turned out to be one of the most highly endorsed strategies in our sample. And both of these strategies were slightly higher endorsed among those with higher resilience. So it appears that manifested resilience prior to the pandemic might be promoting more adaptive coping strategies, which could explain some of those prior effects on mental health protection during COVID. So namely, women who showed resilience before now show more adaptive coping strategies during another stressful time. So similarly, these associations looked similar across women who were and were not current healthcare workers, though there may have been some indication that current healthcare workers had higher coping frequency in general, suggesting they may be in situations that simply require more coping. So resilience from trauma may also promote better coping during future stress, which may be a mediator to those mental health outcomes we previously showed, but it also may suggest that these coping behaviors could be a potential pathway to more positive physical health outcomes down the line. And then lastly, again, we're interested in how resilience relates to behavioral and physical health. So in the context of the pandemic, we were really interested in protective and risky behaviors for contracting COVID-19, as well as infection with SARS-CoV-2 or COVID itself. So to look at this, we've used data from KIP, which is our longitudinal study of community-based individuals who'd all experienced trauma prior to the pandemic and have been surveyed 3 times since COVID began. So we included 2 resilience measures at baseline, a self-reported trait measure, which was again a 2-item Connor-Davidson resilience scale. That's a self-assessment of one's ability to recover from stress, as well as manifested resilience, which was operationalized as residual resilience, where we regressed a composite psychological distress variable on the count of traumatic events experienced, and then extracted those residuals. So we examined these 2 resilience measures in relation to average engagement in protective behaviors against COVID, so wearing masks, washing hands, isolating from others, and then risky behaviors, so going to indoor bars and restaurants, socializing indoors, attending large events, with each of the behaviors rated on a 5-point scale from never to always. And then we also examined self-reported infection with COVID-19 at each wave of follow-up. So adjusting for covariates, both trait and manifested residual resilience at baseline were unassociated with COVID-19 related behaviors across time. However, both of these measures were associated with lower odds of contracting COVID-19. So despite being unassociated with these self-reported COVID-19 related behaviors, which themselves are related to COVID-19 risk, these resilience measures were associated with lower risk for infection. So resilience, again, was not associated with COVID-19 behavior engagement, either protective or risky. In contrast, resilience was associated with lower odds of disease across follow-up. So the manifestation of resilience, or our perceived resilience overall, may be less linked to these behaviors that we assessed, but it does seem to be influencing infection risk. And that's potentially via other pathways or by other mechanisms beyond these reported behaviors that we assessed, such as potentially other behaviors or other risk factors or socioeconomic or psychosocial factors that we were unable to look at, or even potentially some markers of physiological or biological risk for the infection. So now I'll draw some takeaways from these findings. So I found that across studies, the different operationalizations of resilience may not necessarily be tapping into the same underlying construct. So as there are no agreed upon gold standards to measure resilience, the choice of the measure should depend on the population, the context, and the research question. And that choice will be very important and should be thoughtfully made and adequately justified. So what does seem evident from this work and the literature more broadly is that when considering psychological resilience to trauma or adversity, researchers should consider not only the absence of clinical distress, but the full range of the mental health spectrum. And that's important for holistic health in general, but it also may be key to the promotion of physical health. And now, despite the variability in resilience measurements, it seems that across various samples, different operationalizations, and different outcomes, most of our findings suggest that manifesting positive psychological health in the face of adversity is associated with favorable behavioral or physical health outcomes. So in other words, demonstrating resilience to trauma may offset some of the negative effects of trauma or adversity. So future steps, of course, will be to replicate these findings with more follow-up and more diverse samples and to probe the resilience operationalization. And additionally, if resilience may be offsetting risk, why is that? So is there something inherently inherent to resilient individuals that makes them healthier? Do they have access to more internal and external resources, which help them bolster these positive outcomes? Is it that the process of overcoming adversity psychologically is somewhat beneficial to later physical health? Or does later positive mental health reverse or mitigate biological or physiological damage? So there are a lot of future questions that can be asked about mechanisms underlying these relationships. However, I hope I've made the case that psychological resilience outcomes are relevant for physical health, and that while resilience is an important goal in its own right, it may be additionally helpful for lifelong physical health and health into the future. And so with that, I will thank the center again for inviting me here to give this talk and for supporting me during my dissertation, as well as my other funding sources. And I'll thank my mentors and collaborators, both from Harvard and MGH and here at UCSF. And I also thank the participants of all the studies that I've shown for donating their time to these important research efforts.
Wonderful. Thank you so much, Kristen. You covered a lot of ground in this very short presentation. So there are at least a couple of questions. For people who have questions, please put them in the chat. We are tracking them, monitoring them, and we will ask those questions of Kristen. So there's one from Koichiro. It's a very technical question. I can read it for you. When quantifying residual resilience, are results sensitive to functional form specification for the relationship between adversity and outcome? Example, non-linear regression as opposed to linear regression. So.
Yeah, thanks, Koichiro. That was a great question. We have looked at all of the, examined kind of the distribution of the relationship between the adversity exposure and the psychological health outcome. And they've typically not been greatly skewed or in violation of sort of linear regression assumptions. So to this point, I'm trying to think of all the different studies. It hasn't really been an issue, but I think that's a really great point, as there is sometimes sort of a more, potentially exponential effect or a different functional form of the relationship between whatever measure of trauma burden you're assessing and psychological health. And that's definitely something that I'll be more aware of. I also haven't seen any other studies who have sort of modeled it differently than a linear regression and simply extracted like ordinary least squared residuals from it. But yeah, great point. I'll definitely consider that in future work too.
Thank you, Kristen. I see Claudia has two questions and she has her video on. Claudia, do you want to go ahead and ask them? So, you're on mute. I can go ahead.
Yeah, I had a little pop-up message saying I could not talk, but no, I can talk. Nice to see you, Kristen. Really great talk. I've always been a big fan of your research, so now I can say it publicly, but I think it's super important. I was just wondering, first, when you were presenting these different conceptualization of resilience and the Grady study, it seems like, and maybe I missed something, but it seems like some skills were explicitly capturing some form of exposure to trauma versus others were solely capturing depression or some kind of positive affect or positive functioning? And do you think that that's kind of one of the main driver of not seeing stronger correlation between those constructs, since adversity is such an important part of resilience per se?
Yeah, it's very good to see you too. Let's see if I can go back really far. Well, so it's definitely possible. So some of those operationalizations did not include adversity. The entire sample was exposed to adversity. So, okay. Which we kind of, a priori decided that you kind of can't show resilience in this way unless you've sort of experienced adversity according to our, conceptual definition. So the first three don't explicitly incorporate child maltreatment or severity or anything in their definition. So the only one that explicitly includes that is the residual resilience variable, and it actually, we used a measure of severity of childhood maltreatment, which I think is probably a better, less crude version of, rather than saying, okay, the entire sample is has experienced some form. So it's possible that the fact that we incorporated that measure of severity of maltreatment in this fourth definition might have distinguished it from the other measures. But I also think that a big distinction is self-reporting, I think I can recover from stress well. I think I'm, sort of a resilient person, is potentially tapping into a different underlying construct than just what are your symptoms in conjunction with your experience of adversity. Yeah, and again, this is only among one sample that's pretty specific and not super big or representative. So it would be really interesting to kind of look at different operationalizations and how they compare to each other among different samples and using slightly different measures.
We're looking forward to see your work doing this, I guess.
Yeah.
Yes. And my other question was, and I posted it before your third part of COVID, so it was partly answered, I guess. But I'm really interested in how people regulate their emotions and cope with stress and these kind of more processes from the psychological standpoint. And while I was listening to you, I was wondering, where does that fit into the resilience construct? And now you presented results where you say, well, if you're more or less resilient, that will impact the kind of coping strategy that you will engage in the context of COVID. So are you conceptually thinking that it's more consequence than resilience, or is it part of the resilience definition? And I'm pretty sure there's no right or wrong answer at this point, but I'm just curious to hear your thoughts about that.
Yeah, that's a great point. In the way that I'm defining resilience as this sort of manifested outcome, I wouldn't incorporate, emotional regulation or sort of those processes as part of the definition. I would sort of think about it as it's possible that emotion regulation, skills or capabilities have allowed people to become more resilient or have, gotten them to the point where they've been able to show positive psychological health despite trauma. And then I might also hypothesize, like we saw in that study, that people who've shown higher levels of resilience might in turn have more of these emotion regulation skills or more positive coping capacities. So I don't know if it's it was an existing thing that helped people get resilient and then they maintained, those like cognitive or behavioral skills, or that it was, came about. But it would be really interesting to look at, whether it's a sort of a precursor or a consequence, or both, probably.
Yeah, I guess it's probably both, but just looking at like bidirectional relationship and where you see the stronger effect would be really interesting. Mm-hmm.
Yeah, absolutely.
Thank you so much.
Thank you.
If other people have questions, please put them in the chat. We just have about 3 or 4 minutes. While just waiting for any questions, Kristen, I have one question which I want to build on Claudia, but somewhat less technical. did I understand correctly that if you're resilient, you're lower odds of infection, COVID? Did I get that right?
Yeah. Yeah, let me scoot down to that. So yes, resilience according to both a self-reported scale, sorry, I have a lot of slides, and resilience as kind of I've defined as this sort of manifested outcome, which was based on lifetime trauma exposure and psychological functioning early in the pandemic. So both of those were related to lower odds of reporting a COVID infection across basically August of 2020 to August of 2021. So
what would be the mechanism? Is it because they're less likely to engage in risky behaviors? I'm just curious.
Yeah.
So
that's a great question.
I'm sorry, go ahead.
No. I was going to say, so that was our hypothesis, which is why we kind of started with these protective and risky behaviors. And resilience was unassociated, and unadjusted and adjusted. And these are sort of repeated measures models across 3 time points. So I would have hypothesized that resilience might be associated with more protective behaviors against COVID, less risky, and that might have influenced their COVID risk. And so this wasn't really what I was thinking was going to happen, especially like I ran these models first, finding no association, didn't think I would find an association with COVID infection itself. So I don't know what other mechanisms might be at play. It could be other behaviors that we weren't assessing. It could be, we adjusted for a range of sociodemographic and socioeconomic factors, including, employment status and sort of living situation. So other sort of like social relationship type variables that might be related to resilience and risk for infection. But I'm not entirely sure what's explaining these findings for now. Yeah.
I'm also wondering if you were to repeat it today, replicate it, where the infections have been more widespread. Now almost everyone has it.
Yeah.
If the findings will still hold or not. I'm just curious, speculating.
Yeah, totally. And that's a good question. So this study, we are actually, we just finished our 4th wave of survey assessment. So we actually got a lot more COVID cases during the sort of Omicron wave. So we'll probably extend and try to see. Yeah. And so with a more common outcome, I don't know if it'll look the same, but it will be interesting.
Wonderful. We are right on time, Kristen. That was so wonderful. As I said, you covered a lot of ground and, in both methodological and theoretically rigorous. Very well done. Thank you so much for doing this. I also want to thank everybody for attending this webinar. Next webinar is on March 22nd. Dr. Shekhar Saxena, who is a professor of practice of global mental health at the Department of Global Health and Population at Harvard Chan, will be the speaker. His expertise includes providing advice and technical assistance to policymakers on prevention and management of mental, developmental, neurological, and substance use disorders and suicide prevention. So please feel free to attend it. It's on March 22nd from 1 to 1:50 p.m. Also, this is being recorded, so please go to the center's website. You can and RSVP. You can find a lot more information there. So thank you, Kristen, again for doing this. It's great to see you, and thanks everyone for attending this meeting.